Okay, once again, good afternoon. And thank you for coming. Okay. Yes. Okay, so please lend me your ear. This is my first speaking engagement here in Saudi, and I'm nervous. Yes. Okay, so my topic for today is all about congestive heart failure. But this time, we will not only be focusing on the medical perspective, but of course, on the nursing perspective. Okay, so when you hear the word congestive heart failure, what comes into your mind? Disease. Okay, what else? Aside from disease, what else? Who answered that? Okay, love? Okay, yes, no? We actually associate heart, okay, with love, but actually, it's not the heart that controls love, but it's the hypothalamus. So next time you tell, I love you, so it should be from the bottom of your hypothalamus. Okay. So for a better understanding about congestive heart failure, let's have a short overview on the anatomy and physiology of the heart. Okay. So the heart is divided, okay, by a structure called, can I go there? Yes, I know. Okay, so the heart is divided by a structure called septum. So the septum divides the heart into right and left. And the heart is divided into 4 chambers. So we have the right atrium, the left atrium, the right ventricle, and the left ventricle. So the atrium, what did you notice about the anatomy of the heart? The heart muscle, what did you notice? Anybody? What did you notice? The heart muscle. Yes, Franz. What did you notice?
I think the oxygen.
Okay, very good. What else? How about the heart muscles? What did you notice? Okay, so you would see that the ventricles are relatively thicker, right? Compared to the atria. What do you think is the rationale? What do you think is the reason why the ventricles are thicker than the atria? Anybody from the group? +5. Well, okay, as we can see, the ventricles are far thicker, right? Thicker than the atria. So it has something to do with their function, because the atria are said to be the receiving chambers and the ventricles are said to be the pumping chambers. So it has something to do with their workload. So there are 4, okay, leaflets or valve that play an important role in circulation. So what is the function of your valves? Yes, thank you, Doctora. The very function of our valve is to control blood flow and, of course, to facilitate the unidirection of blood. So it prevents regurgitation or backflow of the blood. So we have, okay, the tricuspid valve, which is located between the right atrium and the right ventricle. And then we have the mitral or the bicuspid valve, which is located between left atria and the left ventricle. We also have the pulmonic valve and the aortic valve. Okay, so do you still remember your adult circulation? Do you still remember your adult circulation? Yes or yes? Yes or yes? Okay, so I suppose the answer is yes. Okay. So the circulation, okay, let's start the circulation, okay, from the inferior and the superior vena cava. Okay. So unoxygenated blood that comes from the lower part of the body will take the inferior vena cava as their pathway. Okay? And then the blood that comes from the upper part of the body will take the superior vena cava as their pathway. And then from the vena cava, okay, the blood, take note, unoxygenated blood will go to the right atrium. And then from the right atrium, it will go directly to the right ventricle, passing the tricuspid valve. And then from the right ventricle, it will now go to the lungs, passing the what blood vessel? Pulmonary artery, vein, or what? Pulmonary artery, yes. All arteries carry oxygenated blood except pulmonary artery and plus 10. What is the other exemption? Umbilical artery. Yes, pulmonary artery and umbilical artery. And then from the lungs, what will happen in the lungs? So it is where gas exchange take place, no? So care of our capillary and our alveoli. And then, okay, we will take oxygen and, okay, in exchange with carbon dioxide. And then from the lungs, the oxygenated, take note, oxygenated blood will now return to the heart, to our heart, passing the pulmonary vein. Okay, and then from the left atrium, it will now proceed to left ventricle, passing the mitral or the bicuspid valve. And then from the left ventricle, it will now proceed to the, what is the largest artery? Aorta. Thank you. So it will now go to the aorta, and then oxygenated blood will now distributed to the different parts of the body. Okay. Do you have any question? None so far. Okay. Okay. So let's now go to congestive heart failure. So congestive heart failure, as we all know, is an illness of the heart. So what else? When you hear the word congestion, what comes into your mind? Yes? Yes, John? There is blockage or blocking, stoppage. Yes. Okay. So what else? Any other definition what congestive heart failure is? Do we have a cardiologist here? Okay. So when you hear the word, next time you hear the word congestive heart failure, so don't forget that it is actually a disease, no? It is an illness in which the pumping action of the heart becomes less and less powerful. And then what will be the sequela? If the contraction becomes less powerful, what will happen? Yes. So there will be decreased oxygen throughout the system or throughout the body. So in short, CHF is a condition in which the heart function, no? The heart function as a blood becomes, as a pump, I should say, becomes inadequate to meet the need of the body. So the heart failure is an illness in which the pumping action of the heart becomes less and less powerful. Okay, so there are different causes of congestive heart failure, no? Okay, so however, the outcome of CHF vary from one person to another. Okay? Naririnig niyo ako sa likod? Okay lang. Okay, the first is coronary artery disease, CAD. What is CAD or coronary artery disease? Okay, guys. Okay? So coronary artery is actually the blood vessel that supplies the heart per se. Coronary artery, it is the blood vessel that supplies the heart. So when there is blockage in the pathway of blood that supplies the heart, what will happen? So there will be inadequate oxygen or blood supply in the heart. So do you still remember your atherosclerosis and arteriosclerosis? What is the difference of those? What is the difference between atherosclerosis and arteriosclerosis? CAD, CAD, what? So when we say atherosclerosis, yes, Franz. Go ahead.
I think it involves
Okay. So when we say atherosclerosis, okay, so can you imagine, no? We don't have whiteboard marker. So let's imagine the lumen, no? The lumen of our blood vessel. So, okay, in the lumen of our blood vessel, there is this deposit of cholesterol or fat, no? Fat, F-A-T, atherosclerosis. How about arteriosclerosis? So they are related actually. But when we say arteriosclerosis, there is hardening. Why? The lumen of the blood vessels become hardened or hard because of the presence of plaque deposit or our cholesterol. So they are related. So that is the difference between atherosclerosis and arteriosclerosis. So when there is fat deposit on the lumen of the blood vessel, so there will be, what will happen to the circulation? Do you think the blood supply will still be adequate even when there is blockage? No, it will not be enough to meet the need of the body. Do you want to add something? Question? Violent reaction? None. Okay. Another is heart attack. So what is heart attack? Yes, Franz. Sudden what? Sudden? Okay. So when we say heart attack, there is sudden, no? Yes, correct. There is sudden stoppage of blood supply in the heart. And again, it is related to coronary artery disease. And then what will happen when there is blockage or stoppage in the blood flow of, okay, in the blood vessels that supply the heart? When there is decrease, okay, decreased blood flow resulting to decreased blood supply and then resulting to decreased oxygen supply in the heart muscle. And when there is decreased oxygen in the heart muscle, what will happen to the heart muscle? It will what? It will not what? It will eventually yes, it will eventually necrose or die. So that is our myocardial infarction. No, myocardial infarction. So a decreased blood supply will result to decreased oxygen. Decreased oxygen will lead to decreased function, and then eventually the heart muscle will necrose or die. Another, okay? Another is cardiomyopathy. Cardiomyopathy. Cardio means heart, myo, muscle, pathy is illness. So cardiomyopathy is an illness of the heart muscle. So it may be the pericardium, the myocardium, or the endocardium. So it involves the heart muscle. So a perfect example is your what? Pericarditis, the Gobs infection. Do you still remember your Gobs infection? Your group A beta hemolytic streptococcus infection. So another cause of cardiomyopathy. And of course, conditions, number 4 cause, conditions that overwork the heart. So can you give an example of a certain condition that will contribute, okay, to the overworking of our heart? Valvular disease. Valvular disease. Okay, so what are our valvular diseases? mitral valve stenosis, mitral valve regurgitation, patent, okay, later. Okay, what else? Yes, Doc. Hypertension, very good. Another condition that will lead to the overworking of the heart is hypertension. Okay. How about illnesses that involve the thyroid? Yes, thyroid diseases. Remember that in thyroid diseases, the metabolism is fast. Then, the heart needs to compensate. So, meaning it has to double its work as a pump. So, thank you. Okay, and another condition that will lead to the overworking of the heart is, of course, congenital diseases. Your patent ductus arteriosus, patent ductus venosus, and your foramen ovale. Okay. Do you have any question? Natatakot ako pag ganyang tahimik kayo. Okay. Mas papanganib daw ang tubig na yung ilog pag tahimik. It should be in English. Never mind. Okay, never mind. Okay, so Doctora, actually I was trying to crack a joke, but in vernacular, in our native tongue. And then they asked me to translate it in English. And then I told them, never mind. Okay. Okay, so clinical manifestations or your signs and symptoms of CHF depends on what particular part of the heart is affected, right? Right. Okay. So, yes, Sir Hussein. Okay. Okay, so let's now proceed to the clinical manifestations of left-sided heart failure. Oy, alam ko, pag L, left-sided, L is to lungs, right? Okay. Okay? So, left-sided heart failure. So, do you still remember the adult circulation? Okay, the left side. I have to stay here. That is according to Sir Hussein. Okay. Yes. May tali ako. So, I have to stay here. So, let's go back to the... Okay. Okay. Okay, sorry, Doctora. Okay, let's proceed. So when there is congestion on the left side, right or left? Left side of the heart, so what will happen? Left side, there is congestion. So, what will happen when there is congestion on the left side of the heart? So remember that the left side of the heart is the receiving chamber of blood that comes from the lungs. And therefore, when there is congestion on the left side of the heart, what will happen to the lungs? Yes, no? There will be pulmonary congestions. Okay, so our symptoms, okay, has to do with pulmonary congestion. Okay, so there is dyspnea. During my first year, freshman in college, we pronounced it as dyspnea. So it should be dyspnea, okay? So tachypnea, crackles, okay? Cough, okay? Paroxysmal nocturnal dyspnea. What is paroxysmal nocturnal dyspnea? We are already familiar with the 4. How about 5? Paroxysmal nocturnal dyspnea. Okay, nocturnal night. How about paroxysmal? There is sudden onset. When we say paroxysmal, it is a sudden onset of nocturnal dyspnea. Why at night? Why not in the morning? So that you have reason not to go to duty. Why at night? Nocturnal. Why at night? Why? What is the rationale? Yes, no? There is, because at night there is increased blood flow in the heart. Why? Why is it that there is increase? Yes, very good. So it has to do with the position. So when you are in supine position, that fluid, okay, blood fluid in your leg will, okay, go to the circulation and then it will add to another burden to the heart. Okay, and another thing, when you're lying, remember that the organs in your abdominal cavity will what? Will push your lungs. No, will compress your lungs or your heart, and therefore this will contribute to paroxysmal or sudden onset of dyspnea at night. Okay, another is increased BP. Cyanosis. Okay, so cyanosis is actually a chronic sign of CHF, no? And this is associated, of course, to hypoxemia or decreased oxygen level in the blood. Okay, so another is easy fatigability. Okay, do you want to add something? None so far. Okay, so now let's proceed to right-sided heart failure signs and symptoms. So when there is congestion, remember, that our right side are the receiving chamber or receiving part of the blood that comes from the system, right? We have the inferior and the superior vena cava. So when there is right-sided heart failure or congestion, this will, cause severe dyspnea and orthopnea. We know what dyspnea is. How about orthopnea? What is orthopnea? Nya. Yes, ma'am. Okay, yes, it is a type of dyspnea when you are in lying position. Okay, thank you. Okay, so another is pallor. Pallor, okay. Tachycardia or tachypnea. Okay, expectoration of blood thins protisputum. Okay, so actually, this expectoration of blood thins, it should be under left-sided, no, left-sided. Okay, adventitious breath sound upon auscultation. Okay, it should be still under the left-sided, no? Okay, so there is also bubbling respiration because of the presence of fluid in the lungs. And since you are experiencing difficulty of breathing, so you will experience, of course, acute anxiety, apprehension, restlessness. Okay, there is also profuse sweating. So I have profuse sweating, but I'm not suffering of CHF. Okay, definitely. Okay, cold clammy skin and cyanosis. And of course, when we experience difficulty of breathing, so what will happen? So the body will compensate. So how are you going to compensate with difficulty of breathing? Nasal, flaring, and of course the use of accessory muscle when breathing. So you have your sternocleidomastoid muscles. Okay. Okay, so do you have any question? Additional information? No? Okay, so let's now proceed to the collaborative management of congestive heart failure. Okay, so medication. Okay. Yes, ma'am? Do you have any question? Okay, so none. Okay, so the first medication is cardiac glycoside. So do you still remember your cardiac glycoside, your digitalis, your lanoxin? Okay, the white one. Okay. Nakasulat, Glaxo welcome. Yung pala yun, no? Okay, so the digitalis preparation or your lanoxin. So digoxin is the drug of choice. Okay, so it is said to be the drug of choice because of its effect. So number one is the positive inotropic effect, and the negative, another is the negative chronotropic effect. So positive inotropic effect because, lanoxin play an important role in what? When we say positive inotropic, it is strengthened, no? It strengthened the force of cardiac contractility. And when we say negative chronotropic, it regulates heartbeat. So again, positive, it increases the force of cardiac contractility, and then Negative chronotropic, it regulates the heart rate. What is the normal heart rate? Yes, Francis. 60 to 100. Yes, ma'am?
70 up to 90.
70 up to 90. Oh, different authors, different normal values, but actually it is still under the normal range. Okay? So, however, even though cardiac glycoside or our lanoxin is the drug of choice, okay, it is also associated, no, especially if the patient will be taking, okay, the lanoxin for quite long. So, the patient might be at risk of developing. What is the most dreadful complication of cardiac glycoside? Very good. So, digitalis toxicity. No? So, digitalis toxicity is, okay, a serious and potentially fatal complication of digitalis, okay, or cardiac glycoside. What is the antidote for digitalis toxicity? Digibind. Very good, Francis. Okay. So, digibind. So, what are the, okay, clinical manifestations of possible, okay? Okay, digitalis toxicity, anorexia, nausea, and vomiting. Okay? So, another is arrhythmia. Another clinical manifestation of digitalis toxicity, arrhythmia. Okay? So, another is weight loss, cachexia, neuralgia, and in male, okay, prolonged use of digitalis toxicity may result to gynecomastia or female breast enlargement, decreased libido, and impotence. Okay, so what will be, okay, the antidote is digibind. And then for nursing responsibilities, what will be responsibility when giving cardiac glycoside or lanoxin? Okay, you have to what? Okay, the first is, of course, you have to assess vital sign, specifically the heart rate before administration, and it should not be given if it is less than normal. So another is for us to assess signs of digitalis toxicity. Alam na natin yun. Bradycardia, altered. What is the hallmark sign of digitalis toxicity anyway? What is the hallmark sign of digitalis toxicity? Yes, okay, visual impairment. So, yes, there is yellow halo formation on images. Do you know what halo is? Do you know what halo is? Did I bring with me my halo? Okay, angels of halo. So, halo formation, okay, on images. That is the hallmark sign of digitalis toxicity. So, how are we going to know? Aside from those manifestations, how are we going to know that the patient is already suffering digitalis toxicity, aside from the clinical manifestations mentioned? How? Through? But actually, that is a collaborative, collaborative intervention. You have to, as ordered by the doctor, okay, with the help of the medical technologies, of course, the therapeutic, okay, digitalis level should be monitored. So, what is the therapeutic level of lanoxin? What? What is the therapeutic level? 0. What? 0.5 to 2. Take note, nanogram per deciliter. Ganun siya kaliit. No? 0.5 to 2 nanogram per deciliter. Nano, as in unano, small. Nanogram per deciliter. Okay? Next, aside from digitalis, another group of drug that is used in CHF is the angiotensin converting enzyme inhibitors and our vasodilators. No? Our ACE inhibitors and our vasodilators. So what is the function of our ACE inhibitors? ACE inhibitors, they inhibit the conversion of angiotensin 1 to become angiotensin 2. Because angiotensin 2 is a potent vasoconstrictor. And when there is vasoconstriction, what will happen to the blood pressure? It will be increased. Okay, so they need to inhibit, okay, the angiotensin converting enzyme. Can you give an example of ACE inhibitors and or vasodilators? Your pril group, your enalapril, captopril, okay, captopril, capoten, okay, enalapril, your vasotec, okay. Another group of vasodilators is your hydralazine. Okay, hydralazine, famous brand. Hydralazine, apresolin. Yes, hydralazine, apresolin. And of course, your nifedipine. Okay, and there are instances wherein beta blockers are also given. Ano yung mga beta blockers natin? Olol group, metropolol. Okay, so, okay. Okay, and another group of drug is the dobutamine. Okay, there are instances wherein dobutamine are also given. Okay, so dobutamine is classified as sympathomimetic. Okay, I still have 15 minutes. Okay, sympathomimetic, why? What is the function of sympathomimetic drugs? Sympathomimetic, from the name itself. Sympatho refers to the sympathetic nervous system, and mimetics meaning mimic. Mimic. What does mimic means? Okay, same, or to imitate, because sympathomimetic drugs, just like the dobutamine, mimics the action of the sympathetic nervous system, particularly on the increase, okay, strengthened force of cardiac contractility. So that is the very function of dobutamine. Okay. So for the adverse effects, GI distress, dizziness, skin rashes, and of course, hypotension. So our responsibilities as nurses depend on the presence of, okay, adverse effect. So when there's GI distress, so you have to instruct the patient to, when there is GI distress, what is your responsibility? Oh. Okay. Ang walang kamatayang, small frequent feeding, offer cracker, instruct patient to avoid spicy food, etc., etc. And when there is dizziness, what will be your responsibility? Instruct the patient to move slowly, instruct the patient to avoid driving when taking this drug, and okay, etc. Okay, and in hypotension, of course, you have to monitor the blood pressure. Okay? So another group of drugs are our diuretics. So diuretic drugs or diuretic therapy. So diuretic drugs facilitate the excretion of sodium and water. Remember that patient with CHF is suffering, okay, fluid accumulation, edema. No, edema. What type of edema? I forgot to mention. It's not written, no? Okay, especially in right-sided congestive heart failure, there is bipedal edema, and then if it's not treated, it will result to ascites. What is ascites? What is the difference between ascites and anasarca? Ascites and anasarca. Ascites or ascites? Okay, thank you, Doctora. Yes, no, so ascites is the accumulation of fluid in the abdominal cavity, and anasarca is defined as generalized edema. Okay, thank you. So therefore, since the patient is suffering from fluid accumulation in the system and in the pulmonary, in the pulmonary area, so the patient will be subject to diuretic therapy. Okay, so there are different classes of diuretics. No? So we have high ceiling loop diuretics, benzodiazide diuretics, potassium-sparing diuretics, and osmotic diuretics. So high ceiling loop diuretics, a perfect example of that is furosemide, no, the Lasix. So it is classified as loop diuretics because it takes effect in the loop of Henle. Loop of Henle. Okay, and then the benzodiazide diuretic has something to do with the component. Potassium-sparing diuretic, a perfect example of that is spironolactone aldactone. So, potassium-sparing meaning it is spare, no? It facilitates excretion of water and sodium, but spare. Okay, spare the potassium. And then another is osmotic diuretic. However, okay, rarely, no? So actually, osmotic diuretic is not, it is rare recommended to patient with CHF. But actually, osmotic diuretics are the drug of choice for patients who are suffering from glaucoma and increased intracranial pressure. Right, Doctora? Okay. Okay. So what are the adverse effects? Okay, there will be low plasma ion concentration. You have your hypokalemia, hyponatremia, hypocalcemia, hypomagnesemia. Okay. Okay, so there will also be, okay, natriuresis or increased, okay, what is natriuresis? There is excessive excretion of sodium in the urine, okay, and kaliuresis, of course, the excessive excretion of potassium in the urine, okay. Okay, another is orthostatic hypotension. So what is orthostatic hypotension? I still have 10 minutes. What is orthostatic hypotension? It is a type of what? Orthostatic. It is a type of hypotension that we usually experience when there is sudden change of position. For example, from lying and then suddenly you stand. So you will experience, okay, dizziness. So that is orthostatic hypotension. Mabilis ba ako? Okay lang. 10 minutes. Okay? And dehydration. So you have to take note, guys, okay, that the most serious side effect of diuretics is the loss of potassium and water. Loss of potassium and water. So our responsibility, of course, our responsibilities depend on the presence of, okay, signs and symptoms, adverse reaction. So you have to assess signs of hypokalemia. So what is the sign of hypokalemia? What are the signs of hypokalemia? Muscle weakness. Okay, and remember that your heart, including mine, is made up of muscle. And therefore, okay, it's not spare. Okay, so there will also be, okay, we should give potassium supplement. Okay, we have to instruct the patient of the foods rich in potassium, except if the patient is taking potassium-sparing diuretics. Okay, and then the best time, when is the best time to administer diuretic? Okay, the best time to administer diuretic is in the morning and in early afternoon. Why? Why? Remember that diuretics facilitate urination. Okay, so administer early in the morning or early PM. Okay, so that is, of course, to prevent nocturnal diuresis. Because if the patient will be having nocturnal diuresis, anong magiging problema? Sleep pattern disturbance. Yes. And then for the nursing management, okay, I still have 7 minutes. We have lifestyle modification. I know that everybody's hungry, but please bear with me. Okay, lifestyle modification. So you have to instruct the patient about the importance of healthy diet. It should be low sodium, low fat, high in fiber, high in potassium. Okay, you have to instruct the patient to exercise regularly, but do not over exercise. Do not overdo it. Okay, exercise. Okay. So do not overdo it. So meaning you have to plan activities and rest periods. Okay. Okay, so another is the promotion of adequate nutrition. So small frequent feedings. Okay, and then you have to promote rest. Okay, so if the patient is ordered on CBR without BRPs, then you have to explain. Complete bed rest without bathroom privileges. Okay, so you have to encourage them also to use pillows for added support, especially when they want to assume high Fowler's position. Another is gradual ambulation. Okay, so remember that the patient will be prone to orthostatic hypotension. So you have to instruct them to move slowly. So from lying, sitting on the bed, sitting on the chair, and then standing, and then eventually walking. And then assess for signs of activity intolerance. Okay, so you have to ask, is the patient able to tolerate activities of daily living? So if not, then emphasize bed rest. Okay, another is, okay, to facilitate fluid balance. So you have to control sodium intake. Remember guys, that where sodium is, water is. Okay, so monitor INO. Okay, so what else? Aside from controlling sodium intake and monitoring INO, what do you think will be our responsibility in monitoring the fluid status of our patient? Very good. Weighing. Okay, so you have to weigh the patient at the same time, preferably the same weighing scale and the same clothing or dress. Okay, so another is of course administration of diuretics as ordered. Okay, another is providing skin care. So remember guys that edematous skin, okay, is said to be poorly nourished, and therefore it is prone to the development of bed sores. So it is our vital role to provide skin care. Okay, so you have to instruct the patient to change position frequently. You have to make sure that the patient's skin is dry at all times. Okay, especially the sacral area. Okay. And of course, anxiety. So how are you going to decrease the level of anxiety of your patient? How? Yes, very good. Tell me more. Ang walang kamatayang encouragement to verbalize feelings. Okay? So allow verbalization of feelings. That will help alleviate anxiety. Okay? So identify strength that can be used for coping. Administer diazepam as ordered. And guys, it is your responsibility to inform the patient about his or her condition. So remember that if you are knowledgeable, what will happen to your anxiety? If you are knowledgeable enough about your condition, then this will help you, in a way, relieve your anxiety. Okay? So another is providing oxygenation. So of course, encourage the patient to assume semi-Fowler's or high Fowler's position. Okay. And of course, administration of oxygen as ordered. Okay, promoting elimination. How are you going to promote elimination? If the patient is not on CBR without BRPs, then encourage ambulation. You have to instruct increased fluid intake or minimal. Increased fluid intake or minimal fluid intake? Minimal only. Remember that your patient is suffering or having edema. Okay? So, what is Valsalva maneuver anyway? What is Valsalva maneuver? Valsalva. Okay, any other idea? It's not actually the pagpigil, pag-ire. No, that is Valsalva maneuver. So you have to instruct your patient to refrain from doing Valsalva maneuver, meaning avoid straining, because Valsalva maneuver will be detrimental to the heart. Remember that the heart is already suffering. So actually, Valsalva should not be classified as a maneuver. It is an instinct, right? It is an instinct. Okay, but according to the book, it's a maneuver, then so be it. Okay, so encourage to use bedside commode, especially if the patient is on CBR without BRPs, and administer laxative as ordered, and of course, the importance of high fiber diet. Okay, and then facilitate learning. You have to teach client and the family about the disorder and self-care. Okay, you have to teach them on how to monitor signs and symptoms of CHF exacerbation. Okay, so weight gain, dyspnea, orthopnea, etc. You have to plan activity and rest period, and that is to avoid fatigue. And of course, you have to instruct, to emphasize to your patient to take medication religiously. Okay, and then of course, the importance of follow-up, check-up. Okay, do you have any question? Okay, how about the medical management? Okay, surgical management, are you familiar with angioplasty and stenting? We don't have cardiologists here. Okay, valvular replacement, and of course, heart transplant. So those are the surgical management, surgical medical management of CHF. Okay, so thank you so much for bearing with me. Okay, and you can have your lunch now, and thank you very much.